Thank you very much to everyone for sticking around for the last talk. I promise I'll be energetic, and I'm delighted to speak about cancer disparities today. Like everyone else, I was asked to give the top 3 priorities, so I pushed my limits and give you 5. Number 1, improve access to care. I'm going to focus on Medicaid reform as a way to improve access to care. Number 2, to incorporate cancer disparities into national quality efforts. Number 3, prioritize research aimed at interventions to reduce disparities rather than just continue to merely document these disparities. Number 4, improve education and awareness of cancer disparities among health professionals and the public. And number 5, to successfully engage the community to build team-based approach to treat our cancer patients. So the first recommendation to improve access to care, I'll focus a lot on Medicaid reform in the post-Affordable Care Act era. Here are the goals of the ACA, but suffice to say that the cornerstone of this law is the expanded access to Medicaid insurance. The goal was to provide Medicaid insurance to 16 million additional uninsured Americans, of which an estimated 160,000 of those Americans had cancer. That was a really laudable goal, but there are a lot of things that are still to be worked out in the ACA, and I think that's probably going to be the understatement of the day. Lots of things to be worked out in the ACA. But there are serious concerns about what Medicaid expansion will provide for our cancer patients. First, you heard earlier today that 20+ states have decided to either opt out of Medicaid expansion or remain undecided, which means that those states are vulnerable because there will be starting in 2014, reduced federal direct payments to hospitals, including DSH funding, which was supposed to be offset by the federal donation to Medicaid. And also, it's not clear what Medicaid will actually do for a cancer patient. What kind of services will Medicaid cover and provide for our cancer patients? So the major concern is that the Affordable Care Act may actually exacerbate health disparities rather than help them, and that was not the intent of the law. So what about Medicaid? Does it help cancer outcomes? And there are numerous studies that actually suggest that actually Medicaid probably doesn't improve cancer outcomes. This one study is in colorectal cancer, where you can see that patients who are uninsured or had Medicaid, actually having that aspect seem to upstage their colorectal cancer. So if you had stage 1 colorectal cancer and had Medicaid or were uninsured, you had a survival that was slightly worse than if you had stage 2 colorectal cancer but had private insurance. And similarly, if you had stage 2 colorectal cancer and had Medicaid or were uninsured, you had a similar survival as if you'd had stage 3 colorectal cancer but had private insurance. But there's actually conflicting evidence that healthcare reform and Medicaid expansion could be very helpful to health outcomes. In my home state of Massachusetts, we've had comprehensive health care since 2006. And as you can see here, racial and ethnic minority adults in Massachusetts have reported since healthcare reform increases in having insurance coverage, increases in having a usual source of care, general doctor visits, and reduced problems in paying medical bills. But perhaps the most compelling study about the benefits of Medicaid expansion appeared in the New England Journal of Medicine last year. And this study studied states that expanded Medicaid, namely New York, Arizona, and Maine from 2000 to 2005, and compared their health outcomes to adjacent states that did not expand Medicaid. And what they found was that the expansion states had decreased county-level all-cause mortality by about 6% compared to the expansion states. And there were significantly reduced delays in care, and self-reported health increased significantly. So that was very compelling data that Medicaid expansion could be very, very useful and helpful in health outcomes. So to get very specific about what Medicaid actually offers our cancer patients, it's important for the oncology community to really think about Medicaid reform, because entitlement reform is dominating this year's congressional session, next year's, and beyond, I'm sure. But to get very specific, the ACA provides a lot of protections to patients with private insurers and remains essentially silent for patients with Medicaid and sometimes with Medicare. One thing is that I would recommend that we extend ACA clinical trial protections to Medicaid patients. The ACA does mandate that private insurers cover routine costs in participating in cancer clinical trials, but that's not really written in the law for Medicaid patients. And I think many of you who are in the audience or clinicians have probably experienced Medicaid patients not being able to participate in a trial. Another issue is the issue of oral parity. So many of our oral anti-cancer therapies are extremely expensive. They might be as much as $5,000 per month. And many Medicaid programs require that patients pay 20% of the cost of the medication or capped at 5% of their family's income, which could be as much as $1,000 a month. And that's incredibly prohibitive for people on a fixed income. And these are life-saving therapies, and that could be a real problem. So we could suggest that maybe cancer patients could have exempt services for cost-sharing purposes for oral anti-cancer therapies, similar to IV cancer therapies. There's the issue of genetic testing, genetic counseling. The ACA does expressly mandate that private insurers cover screening tests that got an A or B rating from the United States Preventive Services Task Force. It is less clear for Medicare and Medicaid patients, although it's part of the essential health benefits package, but is really silent about the diagnostic follow-up that is required from an abnormal screening exam. And then finally, very pie in the sky, but incredibly important for oncology providers, is that we need to reduce the variability between Medicare and Medicaid physician reimbursement. There was a recent survey that showed that about 1/3 of oncology clinicians are no longer able to accept Medicaid, and most of those clinicians are actually in the community. And that's where most of our vulnerable cancer patients are hoping to be cared for. So that's a real problem. So CMS and others really need to design, implement, and evaluate innovative payment models. Many examples we heard earlier today from Mark McClellan and others. So the second recommendation is to incorporate disparities into national quality efforts. And this requires that everyone needs to understand that equity is a central tenet of quality. I'm going to say it again. Equity is a central tenet of quality. I was very pleased to see in the IOM report about quality of cancer care that just came out that disparities in access to care was right there in the recommendations, and that's incredibly important. But we need to improve and or develop a national quality reporting program for cancer care, and this program must include variables that accurately capture and define disparities variables. And that requires a unified data collection. So for anyone who is thinking about these rapid learning systems and quality programs, it's incredibly important that this be done. We need to create quality measures that are relevant to cancer disparities. And that might include, obviously, more socio-demographic data collection by practice, the availability of interpreter services, and of patient navigation services. The National Quality Forum has already embraced equity as being an important part of quality, and in the August of 2012, they endorsed 12 quality measures that focus on disparities and cultural competency. And in fact, they tagged 60 existing measures as disparity sensitive. 10 of these 60 measures were cancer specific. For those of you who are interested, it's kind of mushed up there, but the URL for the report by the NQF is there. But it's incredibly important that we realize that that we should incentivize practices for doing great care for cancer disparities. And then finally, we need to prioritize research on interventions. There are too numerous to count studies that merely document these disparities, and we need to find ones that reveal interventions that work. And funding agencies should prioritize these intervention studies. One intervention study that was very compelling was recently published in the JCO. That was a Delaware statewide comprehensive colorectal screening program that utilized navigation, innovative payment models, and case management. And what this study showed that was in the state of Delaware over the time of this program, that colorectal cancer screening rates increased among Caucasians, but more notably among African Americans. That among African Americans, they became more likely to be diagnosed with localized colorectal cancer rather than distant or regional disease. And most importantly, they narrowed the gap in survival between African Americans and whites. So this showed an intervention that worked, and there should be more studies funded like this. And then finally, we need to improve education. Everyone caring for cancer patients should have appropriate core cultural competencies, and that should start at fellowship and go beyond continuing medical education, recertification in the boards, and HHS should help and continue to support development of these programs. So finally, here are my top 3 priorities again: increasing access to care by Medicaid reform, incorporating cancer disparities into national quality efforts, and to prioritize research aimed at interventions to reduce disparities. Thank you very much.
20 seconds under. Thank you. Thank you. You talk fast.